So we proceed with our next talk. My dear colleague, Dr. Ahmed Metwally, will talk to us about secondary glaucoma following complicated surgery for cataract, the pathophysiology and the clinical management. Dr. Ahmed, please.
Good evening, everyone. Today I'll talk about the secondary glaucoma that happens after a complicated cataract surgery. Our goal in this lecture is to navigate for early and post and late onset intraocular pressure elevations, and the objective is to understand how and to understand why and how surgical complications disrupt the aqueous humor dynamics. The reality is the modern cataract surgery is highly safe, but complications can rapidly cause severe secondary glaucoma. Challenge is to manage post-surgical intraocular pressure spikes, often more difficult than treating primary open-angle glaucoma. Our presentation timeline is grouping the complications into early onset within days or versus the late onset within weeks to 2 years increase in intraocular pressure. Regarding the early onset open angle pathways, which is glaucoma that occurs the first day and up to 7 days after the operation. First, the use of the OVDs, with high viscosity or cohesive viscoelastic devices inside the eye are kept without wash, can pack the trabecular meshwork. Severe postoperative uveitis or tuberculitis increase the intraocular pressure by inducing trauma to an inflammatory cascade, blocking the trabecular meshwork also. Hyphema and ghost cell glaucoma, red blood cells left inside the anterior chamber after cataract surgery can block the trabecular meshwork. Lens particle glaucoma with rapid liberation of the cortical matters and remnants during phacoemulsification, leading to acute mechanical trabecular meshwork blockage. Also, of the cause of the early onset angle closure glaucoma, true pupillary block, mechanical occlusion of the iris IOL or the iris capsule interface, especially in sulcus-placed IOLs without an iridotomy. Aqueous misdirection, which is called malignant glaucoma, shift of the fluid into the vitreous cavity, causing anterior displacement of the IOL iris diaphragm, characterized by a uniform flat anterior chamber. Also, a suprachoroidal hemorrhage or effusion will cause a sudden intraoperative or early postoperative hydrostatic shift, forcing forward push mechanism. Regarding the late onset open angle glaucoma and complex syndromes, which occurs weeks to 2 years later, the uveitis glaucoma hyphema syndrome, which is chafing of the iris of the IOL with the iris auxiliary body, causing mild uveitis and hyphema that can block the trabecular meshwork with time. Steroid-induced glaucoma, excessive use of steroids after surgery modify the trabecular meshwork and leads to aggressive topical steroids glaucoma. After aggressive topical steroid regimens for either corneal edema or whatever. Delayed phacoantigenic glaucoma, which is granulomatous inflammatory response to a long retained sequestrated lens proteins if they are left without removal. Postoperative aphakia or pseudophakic glaucoma, which is long-term structural changes of the vitreous soluble factors altering the trabecular meshwork health, historically known as secondary glaucoma following cataract surgery. I won't talk about the extreme complication with malignant glaucoma or intra and postoperative occurrence, which is the aqueous misdirection syndrome. The fluid is diverted backwards into the vitreous cavity, pushing the lens, entire lens iris diaphragm forward, and it presented by severe shallow anterior chamber accompanied by extreme IOP elevation, often precipitated by intraoperative zonular laxity or mechanical zonular dehiscence by aggressive surgery, capsule rupture, and or even sudden decompression. This is a short video about the intraoperative complication aqueous misdirection. It's not my case, I just get the idea. As you can see here, while injecting fluid inside the anterior chamber, the fluid is directed into the sulcus area and the fluid shifts behind the lens, causing increase in intraocular pressure, and there is a iris prolapse, as you can see, with high elevation of the intraocular pressure. And here is a vicious circle. You push the iris inside, inject, the iris comes out again, and the fluid goes behind the lens. While the surgeon is injecting trypan blue, the trypan blue goes back in the Burger's space behind the lens, pushing the lens more forward, and the iris prolapse again. This patient is under topical anesthesia, so with increasing intraocular pressure, the patient becomes discomfort and experience severe pain during the operation, and makes him more alert and more uncomfortable, and you cannot complete the surgery comfortably. Fortunately, this patient continues well with the rest of the surgery. After pushing the posterior lip of the side port to get the fluid outside, as you can see in this step, to decrease the intraocular pressure and to be able to reposit the iris again. As you can see here, after continuing the phaco, there is no red reflex. Why there is no red reflex? Because the whole trypan has been transmitted to the Burger space behind the posterior capsule. That's what's called intraoperative aqueous misdirection, and it's a very known complication if you can figure it out early. Diagnostic and clinical evaluation. Patient should perform gonioscopy after the operation, essentially distinguish between the open and the closed angle glaucoma, slit lamp examination, ultrasonography, and detailed fundus examination for dropped lens particles. For the management strategies, as you can see, for viscoelastics, primary medical treatment by giving aqueous suppressants like beta blockers and chromokinase inhibitors, but better if the viscoelastic is very large amount, you should do anterior chamber wash and flush. For the pupillary block glaucoma, mydriatics and myotics depend on the lens anatomy, or you can do laser peripheral iridotomy. Malignant glaucoma, cycloplastic atropine to pull the lens back. Also, capsulotomy or hyalodotomy or vitrectomy in some cases will be the only treatment for these cases. The retained lens matter, I recommend if there is a retained lens matter, you should wash it either in the anterior chamber or do vitrectomy if it's dropped in the vitreous cavity. It's the only way to treat these cases because they develop late onset glaucoma because of the steroids they receive to decrease the inflammation, or because of the lens particle become engaged in macrophages, become taken out by the macrophages, they block the trabecular meshwork. Lastly, the surgical management for these cases, sometimes they need glaucoma drainage devices or trabeculectomy or cyclodestructive procedure if there is the surgery is very surgery carry too much risk for the patient. To conclude our session and takeaway messages, vigilance, the post-cataract pressure spikes require rapid, accurate diagnosis of the underlying anatomical breakdown. Tailored care success relies on fixing the specific surgical complications, example, removing fragments, adjusting the IOL. Prevention, timely medical and surgical steps protect the optic nerve from permanent damage. Thank you.
Thank you, Dr. Ahmed, for this excellent presentation. How about just a very small hint about what about the glaucoma related to the dropped fragments of the nucleus? What is your time frame recommendation for removal?
When I am because I'm a veteran surgery, they call me about the dropped fragments. I recommend to remove it at once during the first primary operation.
Okay, if you are not available on table, what is the time limit that you recommend? Not more than
in the first week.
1 week.
In the first week, maybe next day, but sometimes the cornea is edematous. But we figure it out. We shall just remove the epithelium, and we can perform the vitrectomy well, even if there is a corneal edema.
Okay, thank you.
And it's a vicious circle. If you didn't remove the lens particles, it will become more edematous. The intraocular pressure will become more high, and the trabecular meshwork will be permanently damaged. So as early as you can remove it, even in the first day, second day.
In the second day. Thank you.
And it can be done also under general anesthesia, under sedation, under local anesthesia. You can perform vitrectomy.
The anesthesia is not a barrier.
It's not a barrier.
Okay, excellent. Thank you very much, Ahmed, for this excellent talk.